Welcome to Nurses Lab. Welcome to this masterclass on the 2025 American Heart Association and American Academy of Pediatrics Guidelines for Neonatal Resuscitation. Every birth is a moment of transition, beautiful, unpredictable, and sometimes profoundly fragile. The 2025 AHA/AAP Neonatal Resuscitation Guidelines arrive at a time when newborn care demands sharper precision, stronger teamwork, and a deeper understanding of how infants adapt in their first seconds of life. These guidelines redefine what readiness looks like, from prenatal risk assessment to post-resuscitation follow-up, forming a seamless newborn chain of care that protects infants across their entire journey. Today, we'll break down every major update, explore the science behind each recommendation, and translate the guidelines into practical, real-world actions you can apply immediately in your delivery rooms, simulations, and teaching. If you have not subscribed our YouTube channel, hit the subscribe button, like this video, and share it with your team to strengthen practice. Don't forget to comment with your thoughts. Let's begin with the big picture. In this video, we are going to discuss about newborn chain of care, anticipation and preparation for resuscitation, umbilical cord management, initial steps of newborn care, assessment of heart rate, ventilation and CPAP, oxygen use, chest compressions, vascular access and epinephrine, volume expansion, post-resuscitation care, withholding or discontinuing resuscitation, training and human performance. Every newborn has only seconds to make the transition to life outside the womb. And when that transition doesn't go smoothly, the neonatal resuscitation algorithm guides every critical decision. In this video, we break down the 2025 AHA and AAP algorithm-related updates and changes, so you know what exactly to do for resuscitating a child. Every 30 seconds, a newborn somewhere in the world needs help to take their first breath. The 2025 guidelines introduce a unifying concept, the newborn chain of care. This framework spans from prenatal care to post-resuscitation follow-up, emphasizing that newborn outcomes depend on a continuum, not just the delivery room moment. Section 1. Prevention. Care starts before birth. Neonatal resuscitation doesn't begin in the delivery room, it begins in pregnancy. The 2025 guidelines emphasize comprehensive antenatal care, individualized risk assessment, psychosocial support, nutrition, medication and substance use counseling, screening for environmental exposures, early gestational age estimation, ongoing monitoring, BP, fundal height, labs, ultrasound, fetal heart rate when indicated. The message is clear: healthy pregnancies reduce high-risk deliveries. Section 2. Recognition and activation. About 5 to 10% of newborns need help breathing at birth. The new guidelines reinforce early identification of risk factors during pregnancy and labor, mobilizing the right team before delivery, transferring high-risk pregnancies to higher-level centers when needed, ensuring advanced skill providers are present when risk is anticipated. Resuscitation success starts with anticipation, not reaction. Section 3. Initial steps, the first 60 seconds. The golden minute remains the foundation. Initial steps for all newborns include maintain warmth, dry, warm environment, skin-to-skin contact, cover body and head. For preterm infants, wrap the baby with warm clothes and also use radiant warmer. Assess breathing, provide tactile stimulation if needed, clear airway only if obstructed, delay cord clamping at least 60 seconds while performing initial steps. Skin-to-skin contact continues for at least an hour when possible, supporting temperature stability and early breastfeeding. Section 4. Ventilation, the critical intervention. If the newborn isn't breathing or HR less than 100 per minute after initial steps, ventilation must begin immediately. Key updates reinforce face mask or laryngeal mask as first-line options. Troubleshoot mask leak and obstruction early. Heart rate rise is the best indicator of effective ventilation. If HR doesn't improve, switch to a laryngeal mask or intubation. For spontaneously breathing preterm infants, CPAP helps establish functional residual capacity. Ventilation remains the single most important action in neonatal resuscitation. Section 5. Advanced resuscitation. When ventilation and alternative airway support fail to raise HR above 60 per minute, begin chest compressions. Establish intravascular access, umbilical venous catheter or IO. Administer epinephrine to improve perfusion. Provide volume expansion when indicated. Advanced resuscitation is about rapid, coordinated, high-scale intervention. Section 6. Postnatal care. Most newborns stay with their parents for bonding, breastfeeding, and thermal regulation. But infants who required resuscitation need monitoring of breathing, oxygenation, HR, temperature, glucose, observation for respiratory distress, hypoglycemia, hypothermia, possible transfer to higher level care. The transition from intrauterine life to extrauterine life must be watched closely. Section 7. Recovery and follow-up. After discharge, follow-up is essential, especially for infants who were preterm, had congenital anomalies, or required resuscitation. Care may include tube seating, cardiorespiratory monitoring, provide oxygen, developmental follow-up, early intervention services, social support for families navigating complex care. Recovery is a team effort, extending far beyond the delivery room. Safe neonatal resuscitation begins long before the baby is born. Anticipation and preparation ensure that the right people, the right equipment, and the right plan are in place for every delivery. By identifying risk factors early, briefing the team, and confirming equipment readiness, we create a controlled environment where rapid, coordinated action is possible the moment a newborn needs help. 1. Each birth should be overseen by at least one individual whose sole duty is to care for the newborn, carrying out the initial resuscitation steps and providing ventilation if necessary. 2. A standardized assessment of risk factors should be conducted prior to each birth to evaluate perinatal risk and ensure that an appropriately skilled neonatal resuscitation team is assembled according to the identified risk level. 3. Before each birth, a standardized checklist must be utilized to confirm that all supplies and equipment required for a full resuscitation are available and functioning properly. 4. Prior to a high-risk delivery, the team should conduct a pre-birth briefing to outline possible interventions and clearly designate each member's roles and responsibilities. Umbilical cord management. Umbilical cord management is one of the first decisions made after birth, and it plays a crucial role in supporting a newborn's transition. Delayed cord clamping allows time for placental transfusion, improving blood volume, iron stores, and overall stability in the first minutes of life. In this segment, we explore why timing matters, how cord management fits into the initial steps of care, and what the latest guidelines recommend for both vigorous and non-vigorous newborns. First, let's see about the recommendations for term newborn. 1. In term newborn infants who are stable and do not need urgent resuscitation, delaying cord clamping for a minimum of 60 seconds may offer advantages over clamping the cord immediately. 2. For non-vigorous term newborns and late preterm infants at 35 weeks gestational age or greater, performing intact umbilical cord milking may be considered as a reasonable alternative to immediate cord clamping. 3. The benefits of intact cord milking versus delayed cord clamping remain unclear for term newborns who do not need immediate resuscitation. Now let's see about the recommendations for preterm newborn. 1. For newborns delivered before 37 weeks of gestation who do not need urgent resuscitation, it is advised to delay cord clamping for at least 60 seconds rather than performing it immediately. 2. For newborns delivered between 28 plus 0 and 36 plus 6 weeks of gestation who do not need immediate resuscitation, and when delayed cord clamping is not possible, performing intact cord milking may be a suitable option, not performing immediate cord clamping. 3. Intact cord milking is not recommended for newborns delivered before 28 plus 0 weeks of gestation. Initial steps of newborn care. The very first moments after birth are critical, and the initial steps of newborn care set the foundation for a safe transition to life outside the womb. Before any advanced interventions are considered, we focus on the basics: maintaining warmth, drying the infant, positioning the airway, and assessing breathing. These simple, rapid actions stabilize most newborns and guide the next decisions in care. First, let's discuss about maintaining normothermia at birth. 1. The temperature of newborn babies must be closely monitored and kept within the range of 36.5 degrees Celsius to 37.5 degrees Celsius during the period immediately after birth, including admission and stabilization. 2. It is important to prevent hypothermia, a temperature below 36 degrees Celsius in newborn infants, as it is linked to negative health outcomes. 3. It is important to avoid hyperthermia, defined as a body temperature above 38 degrees Celsius, because it is linked to negative outcomes in newborns. Next, let's discuss about interventions to maintain normothermia at birth. 1. To prevent hypothermia in preterm infants in the delivery room, several strategies can be employed either individually or together. These include using radiant warmers, covering the infant with plastic bags or wraps and a cap, increasing the room temperature, and providing warmed, humidified inspired gases. 2. Positioning newborns skin to skin immediately after birth helps to keep their body temperature within the normal range. 3. For newborns needing resuscitation, interventions that help regulate body temperature can be advantageous. 4. Exothermic mattresses can be used as a preventive measure against hypothermia in preterm infants. 5. For preterm infants, using different combinations of warming methods, often referred to as bundles, can help prevent hypothermia. However, these strategies may also raise the possibility of hyperthermia. Next, let's discuss about tactile stimulation in newborn infants. Tactile stimulation may benefit newborns who show inadequate breathing efforts immediately after delivery. Next, let's discuss clearing the airway in newborn infants. 1. If a newborn requires ventilation and there are signs of airway obstruction, suctioning the mouth and nose may be considered. 2. For newborn infants showing signs of tracheal obstruction during ventilation, intubation and tracheal suction may provide significant benefits. 3. Routine suctioning of the mouth, nose, or throat, including oral, nasal, oropharyngeal, and endotracheal procedures, is not advised for newborn infants, regardless of whether the fluid present is clear or stained with meconium. Assessment of heart rate. The heart rate is the fastest and most reliable way to understand how well a newborn is transitioning after birth. Within seconds, it tells us whether the baby needs simple support or immediate resuscitation. In this video, we break down how to assess heart rate accurately and why every decision in neonatal resuscitation depends on getting this step right. First, let's discuss about assessment of heart rate in newborn infants. An ECG offers a quick and precise method for measuring heart rate in newborns. Auscultation and pulse oximetry can be effectively used instead of ECG to assess heart rate in newborns. Next, let's discuss about assessment of heart rate in newborn infants receiving chest compressions. ECG is recommended for quickly and accurately assessing heart rate during chest compressions in both term and preterm infants. Ventilation and CPAP. In this segment, we break down when to start ventilation, when to choose CPAP, and how these interventions shape the newborn's chance at a smooth, safe transition. First, let's see about ventilatory support. When newborn infants who are gasping, not breathing, or who continue to have a heart rate below 100 beats per minute after proper initial interventions should receive ventilation within 60 seconds of birth. For newborn infants, starting with peak inflation pressures between 20 and 30 centimeters H2O is appropriate, and these pressures should be adjusted as needed to ensure effective ventilation. For newborn infants who are receiving ventilation, administering positive end expiratory pressure, or PEEP, may be considered appropriate. Elevated peak inflation pressure may lead to an increased tidal volume, which can be detrimental and needs to be prevented. Next, let's see about rate and inflation time during ventilation. Providing ventilation at a rate of 30 to 60 breaths per minute is appropriate for newborn infants. Starting ventilation in newborn infants with peak inflation time of 0.5 to 1 second is considered appropriate. For preterm newborns born before 28 weeks of gestation, routinely using sustained inflations lasting longer than 5 seconds to begin ventilation may cause harm and is not recommended. Next, let's see about ventilation corrective maneuvers. When newborn infants need ventilation and initial positive pressure inflations are ineffective, performing ventilation corrective maneuvers can help improve their breathing. Video laryngoscopy is a valuable tool for performing endotracheal intubation in newborn infants. Next, let's see about interfaces to deliver ventilation to newborn infants. 1. For newborn infants with a gestational age of 34 weeks or more, if ventilation with a face mask is unsuccessful, using a laryngeal mask is a reasonable alternative to endotracheal intubation. 2. For newborn infants with a gestational age of 34 plus 0/7 weeks or greater, using a laryngeal mask as the primary device for administering ventilation may be considered an appropriate alternative to a face mask. So what about the devices to deliver ventilation to newborn infants? Let's see its updates. 1. Using a T-piece resuscitator for ventilating newborns, especially those born preterm, may offer advantages over a self-inflating bag, regardless of whether a PEEP valve is used. Next, let's see about providing continuous positive airway pressure to newborn infants. 1. For preterm infants who are breathing on their own but need respiratory assistance right after birth, it is advisable to opt for CPAP instead of intubation and mechanical ventilation. 2. The comparative effectiveness of high-flow nasal cannula versus CPAP for spontaneously breathing preterm infants needing respiratory support shortly after birth remains uncertain. 3. The effectiveness of CPAP and spontaneously breathing term and late preterm infants, 34 weeks gestation or more, who exhibit or are at risk for respiratory distress immediately after birth, remains uncertain. Next, the updates are about oxygen administration during neonatal resuscitation. 1. In newborn infants receiving respiratory support, oxygen supplementation should be adjusted to achieve specific target oxygen saturation levels. 2. A pulse oximeter should be applied promptly to newborn infants who are receiving respiratory support or supplemental oxygen. 3. For term and late preterm newborns born at 35 weeks gestation or later who require respiratory support at birth, it is reasonable to initiate treatment with 21% oxygen. 4. For preterm newborns between 32 and 34 plus 6/7 weeks gestational age who require respiratory support at birth, starting with an oxygen concentration of 21% to 30% may be appropriate. 5. For preterm newborns born before 32 weeks of gestation who require respiratory support at birth, it may be appropriate to initiate oxygen therapy with concentrations ranging from 30% to 100%. Chest compressions. Chest compressions are introduced only when effective ventilation has failed to raise the heart rate, making this one of the most decisive moments in neonatal resuscitation. This segment explains why compressions are started, how they support cardiac output, and what providers must coordinate to give the newborn the best chance at recovery. First, let us see about initiating chest compressions in newborn infants. In newborns, chest compressions should be initiated if, after 30 seconds of effective ventilation with visible chest movement, the heart rate remains below 60 beats per minute. During chest compressions in newborn infants, ventilation with an endotracheal tube is recommended. If endotracheal tube placement is not feasible or is unsuccessful during chest compressions for newborns born at 34 weeks gestation or later, using a laryngeal mask can be considered a reasonable alternative. Administering 100% oxygen during chest compressions in newborns can be considered appropriate. After chest compressions are discontinued, adjust the oxygen concentration as needed to achieve targeted oxygen saturation levels. Next, let us discuss about compression to ventilation ratio and techniques in newborn infants. When performing chest compressions on newborn infants, it is often appropriate to deliver 3 compressions followed by 1 ventilation breath, maintaining a 3-to-1 ratio. The 2 thumb encircling hands method may be a suitable alternative to the 2-finger or other approaches for administering chest compressions to newborns. When performing chest compressions on newborn infants, it is appropriate to compress the chest to a depth equal to 1/3 of its anterior-posterior diameter. When performing chest compressions on newborn infants, it is advisable to compress over the lower third of the sternum, ensuring that pressure is applied above the xiphoid process. It can be appropriate to rotate the person performing chest compressions on newborn infants every 2 to 5 minutes, and to change the compressor during the interval when heart rate is being assessed. Vascular access and epinephrine. This phase begins only after effective ventilation and coordinated compressions have failed to raise the heart rate, making timely access, whether through an umbilical venous catheter or an intraosseous route, the gateway to delivering epinephrine and restoring perfusion to vital organs. Firstly, let's discuss about vascular access during resuscitation. 1. Placement of an umbilical venous catheter is advised for newborns who need urgent vascular access. 2. Insertion of an intraosseous vascular access device may be beneficial for newborn infants who need emergency vascular access when intravenous access cannot be achieved or is not possible. Next, let's discuss about epinephrine administration in neonatal resuscitation. 1. If a newborn's heart rate remains below 60 beats per minute despite effective ventilation and chest compressions, intravenous epinephrine should be given at a dose of 0.01 to 0.03 milligrams per kilogram. 2. If a newborn does not respond sufficiently to an endotracheal dose of epinephrine, it is appropriate to give intravenous epinephrine as soon as vascular access is available without waiting for the usual dosing interval. 3. For newborn infants who require epinephrine, it is appropriate to give a higher dose of endotracheal epinephrine of 0.05 to 0.1 milligrams per kilogram while efforts to secure vascular access are underway. 4. For newborn infants receiving epinephrine, it is considered appropriate to give subsequent doses of epinephrine every 3 to 5 minutes, ideally via the intravenous route, if the heart rate stays below 60 beats per minute. Next, let's discuss about volume expansion. 1. Administering a volume expander can be considered for newborns showing signs of hypovolemia, as determined by their history and physical examination, who continue to have a heart rate below 60 beats per minute despite receiving ventilation, chest compressions, and epinephrine. 2. Administering normal saline or 0.9% sodium chloride or blood at a dose of 10 to 20 milliliters per kilogram can be an appropriate approach for volume extension. Post-resuscitation care. Post-resuscitation care begins the moment a newborn stabilizes because the transition after a critical event is fragile and can shift quickly. This phase focuses on protecting the infant from complications such as respiratory distress, hypoglycemia, and temperature instability, while supporting bonding and communication with the family. 1. Newborns with a gestational age over 36 weeks who present with moderate to severe hypoxic ischemic encephalopathy should receive therapeutic hypothermia in accordance with established protocols. 2. Newborns requiring extended ventilation or advanced resuscitation measures such as intubation, chest compressions, or administration of epinephrine should undergo close monitoring. Early assessment of glucose levels is recommended in the post-resuscitation period, with ongoing checks until stable, normal glucose levels are consistently maintained. 3. Newborn infants who experience accidental hypothermia with a body temperature below 36 degrees Celsius following resuscitation should undergo rewarming. However, the ideal rate at which rewarming should occur has not been established. Withholding or discontinuing resuscitation. When a newborn shows no signs of life despite prolonged high-quality resuscitation, the focus shifts from escalation to ethical decision-making. Withholding or discontinuing resuscitation is guided by the newborn's gestational age, underlying conditions, and the absence of response to sustained interventions. 1. For newborn infants undergoing resuscitation, if there is still no detectable heart rate after all resuscitation measures have been completed, it is important to discuss the possibility of stopping resuscitation with both the medical team and the family. Considering a shift in goals of care is generally appropriate approximately 20 minutes after birth. 2. For newborn infants, choosing not to begin resuscitation and deciding to stop life-sustaining treatment during or after resuscitation are ethically equivalent actions. 3. If a newborn is born with a condition expected to cause early death or significant long-term illness, it is appropriate to consider not starting or to limit resuscitation measures, following thorough consultation and shared decision-making with the family. Training and human performance. The 2025 guidelines strongly emphasize team performance. Recommendations include simulation-based training, structured debriefing, role clarity, and cognitive aids. Let's see the details of this. 1. Spaced training, where instruction is distributed over multiple sessions, may be preferred over massed training that occurs in a single session. Blended learning approaches, which combine face-to-face and online instruction, are recommended when compared to using only one method, whether solely in person or online. Incorporating rapid cycle deliberate practice into instructional design can also be considered. 2. Gamified learning, such as the integration of point systems, group competitions, leaderboards, and progressive challenges, may serve as a valuable element within resuscitation training. Teaching teamwork skills should also be considered as part of resuscitation education. 3. When resources permit, the use of high-fidelity mannequins is suggested for resuscitation training. However, low-fidelity mannequins remain an acceptable alternative if necessary. Both augmented reality, which enhances hands-on experience with virtual elements, and traditional training can be used for resuscitation education, while virtual reality alone is not recommended. The 2025 AHA AAP Neonatal Resuscitation Guidelines represent a major evolution in how we support newborns during their most vulnerable moments. From physiologic transition to ventilation mastery, from team readiness to post-resuscitation care, these updates strengthen every link in the newborn chain of care. Thank you for joining this masterclass. Stay updated, stay prepared, and continue improving outcomes for the newborns you serve.